So I want to introduce Mari Williamson, a nurse, an author, a humanitarian specializing in migratory health from Seattle, Washington. She is the executive director of Insight Collaborative. She helps to oversee emergency aid responses, displacement crisis, COVID-19, and she's facilitated the evacuation of at-risk individuals from Kabul, and she's done a lot of work in the Middle East and Mediterranean region, and will be presenting along with Dr. Michael Drusano, who's a family physician, focuses really in resource-limited environments. He's worked a lot with Syrian and Yazidi refugees in Greece and survivors of the Rohingya genocide in refugee camps in Bangladesh. And the two of them will be discussing moral injury in humanitarian workers. So I think this is very essential and important for all of us. Thank you, folks, and welcome.
Is everybody able to hear okay? I guess I can't hear all of you, but I just want to make sure that people can hear on your end. Okay, cool. I'm getting the thumbs up from Megumi. Oh, I'm getting a nod. Wow, look at that. Cool. Well, thank you all so much for having us. We're going to start just by introducing ourselves. Already read off the bio. Thank you so much for that. But yeah, my name's Maddie. I'm a registered nurse. We are really excited to talk about this topic today, not because it's a particularly uplifting one, but because it is so important. I remember super vividly my nursing instructor asking me if I had maybe experienced moral injury, and I felt like this whole new dimension to my understanding of my own existence opened, and it was liberating, it was healing, and I was just, I was really thankful for that vocabulary and for a way to start to conceptualize my experiences. And so that's what brings me here today. It's why I've pursued moral injury in humanitarians. And Mike, I will hand the floor over to you.
Right. So nice to meet everybody. Sorry we were not able to make it in person. It's also an early morning out here on the West Coast. So yeah, my name is Mike Drusano. It's nice to be, I guess, virtually attending a conference in DC. I'm originally from just up the road in Baltimore. Um, my humanitarian experience in more recent years, yes, was in the Eastern Mediterranean as well as in the Rohingya camps in Bangladesh. But my experience in the humanitarian sphere goes all the way back to 2004, where I was doing volunteer work as a medical student in Botswana at the height of the HIV crisis there. I've also worked in a landmine clinic in Cambodia, Eastern DRC in the war zone in the east, Somalia twice. I was an Ebola responder in 2015 in West Africa, and then helped another organization with Ebola infection prevention and control in Uganda in 2019. So all I can say is it is a pleasure to be here, and thank you for having us.
So we're going to kick off over on, for the person doing the slides, we're on slide number 3, what is moral injury? And we're going to start with a definition of moral injury for those who are unfamiliar. I think it's quite intuitive when you hear the term moral injury, but we've brought some definitions today to help you guys out. So moral injury is an emotional response that occurs when someone is forced to transgress their moral beliefs by either behaving in a way that they feel is not moral or being prohibited from behaving in a way that they feel is moral. And we're going to go to the next slide. Some other definitions that I like. Maya Brownstein wrote, psychological harm incurred from committing, witnessing, or being subject to actions that violate one's moral code. I think that's a pretty good illustration of what it feels like when, as said, we open our phones and we're doom scrolling and we bear witness to a lot of really awful things that go against our moral beliefs. I also really like this definition from Educational Materials by Kelly et al. And their research team. And they call it a constellation of inappropriate guilt, shame, anger, self-handicapping behaviors, relational and spiritual or existential problems, and social alienation that emerges after witnessing and or participating in their case, war zone, working with veterans, war zone events that challenge one's basic sense of humanity. A lot of the times, moral injury might be referred to as moral distress, moral trauma, or moral disorientation. Sometimes, even in the literature, we use different ways to describe this, but all of those fall under the category of moral injury and, for all intents and purposes, have the same effects on people's mental health and well-being. And we're going to go to the next slide. So, moral injury tends to occur following a potentially morally injurious event. These events might include experiencing or witnessing a moral transgression, but sometimes betrayal from leadership in high stakes situations also causes moral injury. A lot of that was observed in military personnel, frontline responders like police and fire, and in health professionals during COVID-19 pandemic when we had all of the bureaucratic stuff happening in hospitals and people felt like that was affecting their ability to care for themselves and for others. This happens, honestly, an umbrella way of understanding potentially morally injurious events is to think of witnessing or experiencing any form of injustice or structural violence that has the potential to be morally injurious. Not all potentially morally injurious events are going to result in extreme or disruptive moral injury symptoms, especially if we have early intervention and appropriate support. Go to the next slide. So what are some of the signs and symptoms of moral injury? Guilt and shame, oftentimes profound. People might feel very regretful. They're likely to be ruminating on the event, so really like thinking through it, chewing through it. Sometimes those ruminations are really disruptive, almost to the point of being flashbacks. People might experience identity disruption, especially those of us who are in helping professions, social work, therapy, health professionals in general, mental health professionals. We've gone into this field because we want to help other people feel better. We want to be a support person. And when we put so much of that into our identity and then realize that the reality of our career or of the situation is not congruent with that identity, it can really shatter our worldview and cause some pretty severe disruption to that identity. Because moral injury is a social wound and our sense of morality is heavily informed by the people in the community around us, when we feel like we have caused a moral transgression, sometimes we isolate or feel a sense of alienation. And if our moral code and our morality is also heavily influenced by spiritual beliefs, whether that's organized religion or a belief in just spiritual and moral connectedness to other people, it can cause pretty severe spiritual disorientation in people as well. Moral injury might appear concurrently or with other psychological conditions like PTSD, depression, or anxiety. And we're going to go to the next slide. Because I think especially when we're working with survivors of torture or people who have experienced humanitarian crisis, forced displacement, like really extreme forms of violence, both physical and psychological, people are likely to have both PTSD and moral injury. And so it's important for us to just distinguish between the two. So this is a really helpful Venn diagram from Lewis. I linked in this, I think you guys get copies of the slides. So I linked the full article in the speaker notes on the slide if people are interested in reading it. But PTSD, as we know, occurs after you have experienced or firsthand witnessed a potentially or actually serious threat to your life and to your physical, psychological, or emotional safety. And so we have that fear-based psychological response, a very visceral response, fear, horror, paranoia, flashbacks, the hyperarousal and hypoarousal responses. But with moral injury, because we've transgressed our moral beliefs, and again, this is a relational wound, we might alienate, you might experience a collapse of your standards or your values, and of course, those sort of hallmark signs of grief and shame, regret, and guilt. Overlapping in the middle here, I think is really important for providers because if we're only treating the signs of PTSD and sort of assuming that because someone is presenting with these symptoms means that they are experiencing PTSD, the treatment for trauma may not necessarily work for the treatment of moral injury. So it's important for us to keep in mind that if we're seeing these symptoms, one or all of these symptoms in a client, in a patient, that we need to consider not only might they be experiencing disordered trauma coping, but they might also be experiencing moral injury. And I'm going to pass the floor to Mike and we'll move on to the next slide.
Perfect. So thank you, Maddie, for the wonderful first half of the presentation. So many ask, does this apply, the concept of moral injury to the helping professions, medicine, nursing, public health, etc.? And the answer is very much so. And this is for a wide variety of reasons. As you see here on the slide, helping professions are much more constrained now than they are in the past. I could give you just some examples from my own personal life. There's more stricter licensing standards. To get my current medical license in the province of British Columbia, Canada, I had a total of 15 different letters of good standing, and they told me it still was not enough for licensure. Rising licensure fees, myself just to practice 1 year within the province of British Columbia as a family physician and not exactly the most lucrative of medical specialties, I must pay yearly $1,900 to the College of Physicians and Surgeons of British Columbia. And recently, my California medical license renewal was up. That was $1,200 for 2 years. A lot of the helping professions have now been experiencing what a lot of people perceive, and correctly so, to be over-regulation. An example that one could say complaints in the past that were dismissed due to their vexatious nature are now being treated seriously. Some examples that I heard, not personally affecting me, but a physician being complained about to the Board of Medicine or College of Medicine, they call it here, because the patient did not like the food in the hospital. And the doctor was forced to answer for that. Also, to the prolonged time to final decision, even in those vexatious cases. As we go on, health system resources, especially during and after the pandemic, especially with the arrival of a private equity into a human need, human service, these resources have been stretched to unsafe levels. Most nurses could be telling you about nurse-to-patient ratios, for instance. There's also the combination of increased expectations from everyone, from patients, from supervisors, from administrators. And after all of that, even more free, uncompensated time is expected to be dedicated to things like workplace certification, for instance, online modules, usually about basic things like hand washing, but in many instances, the tone of which almost implies that the individual is ignorant or intending to cause harm. So this right ahead, I think with the way that the system at large overacts with practitioners, yes, indeed, sets us up for moral injury. Next slide, please. So how are humanitarians affected? You have this at home, you travel overseas to help others, but once you get there, you find that the current humanitarian landscape and the work associated with it bears little resemblance to what we've seen in past generations. We have now the specter of climate change, extreme weather events. We're seeing droughts. Now it seems like every 2 to 3 years, there's a once in 100-year kind of storm in the Caribbean basin, as we saw at the end of last year in Jamaica. Natural disasters such as earthquakes in Syria, in Morocco a few short years back, flash flooding in Libya also a few short years back, infectious disease outbreaks, novel influenza. We've had Ebola, Zika, dengue, chikungunya, COVID-19, political instability in places like Haiti, DR Congo, other countries around the world. And at this juncture, protracted emergencies now appear to be the new norm. Not is it some sort of acute event, natural disaster, external aid arrives until things are more stabilized, until local authorities are able to take over. It now seems as if international organizations have longer presence overseas. Combine this with the number of refugees, the highest it has been in generations. And I think we're all aware of the civil war in Syria, the continued political system and insecurity in Venezuela, long-standing war in DRC, and civilians have been targets in these settings. Many of these refugees are now trapped in conflict settings or have been exposed to extreme conflict. Human rights atrocities, now the new norm. We're aware chemical weapons have been used in attacks, for instance, nerve agents in Syria, white phosphorus in Gaza, and now it appears also in southern Lebanon. Human rights atrocities, the Rohingya in Bangladesh, we're all familiar with. The prolonged military action in Gaza, now appropriately deemed to be genocide. And then even in supposed safe countries, developed countries, we do see as an overriding policy the malignant neglect or hardline containment. Examples that we could give in Calais in northern France at the Mediterranean crossing, in the Greek islands, Rohingya in Bangladesh. And in Bangladesh, we also see the policy of hardline containment, meaning refugees are limited to the camps, cannot exit for really any reason, or if they do, they need several layers of permission granted to them. They're not able to integrate into the surrounding community. And Bangladesh is not a signatory to the 1951 Refugee Treaty, and this is by design. Because if they were to be a signatory, that would then legitimize the presence of the Rohingya there, and then would obligate the Bangladeshi government to provide a certain level of services to them. So, just to continue, many organizations also nowadays seem to focus more on process than results. So, meaning they're just a lot more concerned with policies and procedures respecting the chain of command rather than action and delivery of services. Yes, maybe you saved several thousand people from famine, but was this person made aware before you did it? That sort of seems to override any sort of service that you're providing. The latter being the reason why we went into this field to begin with. We're also aware now, violence and attacks on healthcare workers in facilities, it seems as if it's now a regular occurrence that we hear about in the news. An MSF clinic or hospital have been targeted in conflict zones. Meanwhile, I think if you go back to 25, 30 years ago, it was a rarity and, people were shocked at the news. Nowadays, it almost seems as if people just shrug their shoulders and move on, unfortunately. We have become desensitized to it. As we're also aware, all healthcare workers in facilities have been under barrage in Gaza for about 2.5 years now. Niche causes you'll see on this slide. One example is with polio eradication. You have a lot of people that are working on polio eradication in areas where it's still ensconced, West Africa, Afghanistan, northern Pakistan. And they come back saying, not only do the people in these regions have an understandable mistrust of outsiders, even those from their own country, but many people in areas where polio is prevalent, they say to a lot of the eradication workers, too much attention is being given to polio in the setting of other profound health needs. So, the polio workers will come back stating, yeah, people are saying they're starting to get frustrated. We've been needing running water, sanitation, electricity for years, but all you guys do is keep coming around offering polio vaccines. So this leads to resentment of humanitarian workers as well as their organizations. But nonetheless, us humanitarian aid workers, we have stepped up and done our absolute best to deliver both in an immediate and in a sustained response. But the result of this dedication is oftentimes moral injury. Next slide, please. So for this reason, we undertook a study, the study called Moral Injury Among Humanitarian Personnel, a preliminary examination of associations with rumination and mental health. And this was featured earlier this year in the International Journal of Humanitarian Action. But while there's been more discussion of moral injury in recent years, there still remains a dearth of academic literature about the issue. And most academic literature is usually about veterans. So humanitarians have been overlooked. So we sought to fill in this gap. So again, regarding the effects of moral injury on the mental health of humanitarian workers, close to none. The purpose of this study, quantify the prevalence of moral injury within the humanitarian aid community, but also address its correlation with other mental health outcomes. Next slide, please. So a brief rundown of the study. We had 124 humanitarian aid personnel included. They were recruited to participate in an online study focusing on their work experiences, moral injury, and the mental health outcomes attributable to it. Recruitment was through Facebook and WhatsApp groups, as well as email newsletters. And from there, we were able to conduct snowball sampling. Now, if you're not certain what snowball sampling is, it's used oftentimes in hard to reach groups. This is when study participants are encouraged to let others in their group or within their community know about the study and encourage them to participate as well. So, before starting, participants were allowed to view the study description. They underwent formal consent. Survey was approximately 30 minutes in length. No compensation was provided. The study was approved by the Institutional Review Board, IRB. For those of you who may not be familiar, it's a group of people at a university that determine whether or not the study is ethically sound and where participants are protected to the best of one's capability, protected from harm. So the results showed majority white, majority cisgender women. The mean age of participants was 38 and 2/3 years old, and the standard deviation was 13.66 years, and nearly 50% had worked 5 or more years in the sector. Now, this is where I have immense respect for statisticians. I have a degree in public health as well, and that course, yes, there were moments where I felt like my head was going to explode. But, standard deviation, just to remind everybody, 95% of all participants will be between 2 standard deviations. A standard deviation means the average of deviations from the mean. So 2 standard deviations in both directions from the mean will encompass 95% of all participants. So when we take a look at this data, we could see that 95% of all participants were between ages 11.34 and 65.98 years old. Now, aid organizations are highly unlikely to employ anyone below age 18 in any capacity. What we can assume is that there are a great number of participants below age 38.66. So between that age and age 18, the chunk of the participants were between 18 and 38.66. And that likely there was just a tail of participants heading outwards in age. And anybody that's really participated in humanitarian aid knows many people do enter the line of work later in their career or in life, kind of once they've paid their dues. Next slide, please. So I'll try to be brief here. I know that we're running out of time. So we assessed moral injury and performed statistical analysis. We had 3 different measures, okay? MIESS, Moral Injury Exposure and Symptom Scale, the civilian version. It differentiates between exposure and distress and assesses exposure and distress related to moral injury. MIAS is Moral Injury Appraisal Scale. It inquires about moral injury's origins, self-directed versus other-directed. At least within our study, only a few statistically significant associations were found, namely depression, mania, suicidal ideation, psychosis, disassociation, personality functioning. The more statistically significant correlations were found when examining the other directed MI subscale: depression, anger, mania, anxiety, somatic symptoms, rumination, dissociation, suicidal ideation. The last kind of assessment or questionnaire, MIQH, Moral Injury Questionnaire for Humanitarian Personnel, examining moral injury holistically. There were great statistically significant results here. Correlations were actually in the medium to large range. So in particular with depression, anger, mania, anxiety, somatic symptoms, suicidal ideation, sleep problems, memory issues, rumination, personality functioning, and dissociation. So what we were able to assume once we had crunched all of the data from the population sampled, always important when citing research, the true extent of correlation likely occurred between the results of the MIAS and the MIQH groupings. MIESSC there was very poor fit to the data. So we excluded what we found from there. The rationale for that is within the study itself. Next slide, please. So I'm going to try to wrap this up. Limits, all studies have them. So again, recruitment was only through social media and humanitarian WhatsApp groups, followed by snowball sampling. So of course, there may be people that understandably are not involved all that much in social media, again, for understandable reasons. They may not use WhatsApp or other messaging applications, also for understandable reasons. So we were limited to only those who belong to pre-established social networks. It was only available in English. Many humanitarian organizations nowadays actively do their best to employ locals, and the growing tendency is to do so for many reasons. Avoid saviorism. Locals have the best knowledge of what is going on in each environment, but many may not speak enough English to participate. And I can tell you, as somewhat of a polyglot myself, there do exist different levels of fluency, one of which is being able to express oneself emotionally. The example I could give in Spanish, estoy muy triste versus me siento derrotado. Like I feel very, very sad versus I feel devastated. I feel broken down. But also furthermore, many psychiatric and psychological terms, concepts, afflictions differ between cultures, and what may seem pathologic in one culture is actually very normal behavior in others. One example that I could tell you is there's still a belief in witchcraft in many societies in equatorial Africa. So, that's in more of a Western standpoint, people might cock their head sideways. In West Africa, it's very widely accepted. What we can say is, though, is that the study overall did not reach an adequately representative sample population. Next slide, please. So there are potential effects of this study. I'm going to do my best to wrap this up. The discovery of positive findings then justifies conducting future studies. We even see this in studies with a smaller sample size. So this may induce researchers to take a look at larger and more representative groups of the humanitarian aid community. I could say, humanitarian aid recipients and system users, not necessarily beneficiaries anymore. Trying to lean away from that term comes off as a bit too saviorist, but the humanitarian aid recipients and users are vulnerable. And these individuals deserve to have mentally healthy individuals assist them in their quest to meet their needs and or help reconstruct their lives. So we do that by ensuring the mental health and well-being of the people assisting them. This could impact the structure and function of employee well-being programs and justify funding for them within the humanitarian sphere. But yes, future studies are most certainly needed in order to understand and legitimize the threat that moral injury poses to humanitarian aid workers. Complex humanitarian emergencies, as we established earlier, are not going away. Work environments are getting more challenging. More is expected from us. So that being said, we need and deserve attention to this issue. Next slide. I think this is where Maddie takes over.
This will be me to bring us to a close. And so a lot of people are probably wondering, that's cool. Well, what can I do about this? How can I apply this to my work? What I always tell humanitarian practitioners and anyone else I'm working with, one of the best things you can do is educate yourself, your peers, and your patients and clients on moral injury. Even just giving people that vocabulary, especially native English speakers, can be a really helpful way for people to conceptualize and communicate how they're feeling and what they're experiencing. In your own work, obviously, moral injury is something that we experience when we're trying to support people, especially people who have survived torture. Reflecting on how you stand with personal moral injury inventories, some of the scales that Mike shared in our study might be helpful, and sharing your experience casually with your peers, just that peer support is super powerful. And embracing moral injury as the root. I think this is really important. Obviously, trauma-informed care is a buzzword and it's kind of becoming standard in a lot of health practices, as it should. But I think it overlooks a lot of the times what is actually moral injury. And we are misdiagnosing people at worst, and at the least, we're just really kind of missing the mark. We're misunderstanding the root causes of these feelings. And that can lead to a lot more mental health consequences down the road for ourselves and for patients and clients. So just remember that where there is violence, there is moral injury. There's no situation where violence does not lead to moral injury. And as you're working with people and as you're moving through your own practice, just remembering that can be a really powerful tool. So I'm not seeing any questions from virtual. I can't see the in-person folks, but if anyone has any questions, comments, we're happy to hear them. Otherwise, we hope you guys have a great time at the conference today.